We're excited to have you back. Thanks for coming. And we'll start part 2 of our program planning and evaluation. As always, me and Kat are here. We'll be looking at the chat box, make sure we don't miss anything. Give us a holler if there's any tech issues. And we're excited to have you again. And I'll turn it back over to the awesome Kimber.
Thanks, Em. Okay, so I think I have it set up correctly so that you all just see the slide and not the one that's about to come next. So where we left off, okay, good. We're on step 7 of the 10 steps of the logic model or logical framework model. And so we'll finish that up, and then I have a poll and a really brief breakout room opportunity, because I just wanted you guys to discuss amongst yourselves what planning tool you've used in the past, if any, and then, or we might not even need to do that in a breakout room, but I'll just let you all know that that's the direction I'm heading after I get through the next couple of steps before we come to the evaluation portion of the webinar. And so we'll be up to that in a few minutes here. So the step 7 that we're unpacking here is the point at which we look at the theory of change and the logic model that is kind of underlying the program planning effort that you're engaged in, and also the generation of the problem tree. So the theory of change purpose is really simple. A lot of people think that when they hear theory of change, it's referring to a specific theory that they're going to have to learn, but that's not the case. The theory of change is just your thinking as the program planner about what is the major problem, or what is the primary problem that you're focusing on addressing, and what are the main causal relationships between your program's components. In other words, what is your idea about why your project is going to cause a change? And so the output of the theory of change logic model exercise is the problem tree. And so together with your team, or if you don't work with a team, together with yourself, the exercise that you should be engaged with in step 7 is just figuring out precisely why it is you think that the program that you're designing is going to move the needle on the particular health behavior or health outcome that you're trying to address or trying to affect. And so a very good way to kind of get along the path toward nailing those specifics down is by creating a problem tree. So these problem trees in logic models are like the framework or the 4x4 matrix that I showed you on Wednesday, read from the bottom up. So at the bottom are the causes that you've identified that are feeding into either the behavior or the problem that you're addressing. And at the top is the effect on population health. So again, I'm moving along the COVID-19 example. So the cause in this particular problem tree that I developed for an example or sort of template program planning exercise is that in this hypothetical population, we have insufficient testing for the population size. And that is paired up with the other part of the bottom. People don't know they're infectious with coronavirus. That causes Montanans, in the case of our state, to be unwittingly infecting one another. And the effect of those 3 things together is that Montanans are falling ill with COVID-19. So when you're constructing your own problem tree, just remember that you want to build it from the bottom up, where the causes are at the bottom and the effect is at the top. And that's going to lead you into further thinking and articulation of what your logic model is for your program. So when you're writing a grant, or when you're reading a program description, or writing a program description, or developing a program plan, if there is no reference to a logic model, then there's something missing. So if you're reading someone else's grant application and their logic model is missing, or their theory of change is not explicitly articulated using that language, where the statements are just like I just said, using the language of the logic model behind this program is XYZ, or our theory of change is XYZ, then I would say this is a weak program plan. And either this person needs some consultation and some coaching, and more thought needs to be put into why they think these things are related to each other and are going to have an impact on the health outcome. Or I, as the writer of the program plan, I need to go back and fix this. So what I have here on the slide is just another way of showing a logic model. Like you can do a logic model using a log frame matrix, like with the 4x4 cell, and I'll show you an example of that next. All filled in with inputs and outputs that relate to COVID-19 testing. But you can also see, and oftentimes in program plans or in grant proposals, you also see logic models that are shown, that are written and described like this one that you see on the screen here. And so it just kind of shows a flow of thinking, the flow of logic. And this one is one that I wrote for a grant that we were getting ready to submit and didn't end up submitting because COVID hit. But it was a grant that was looking at improving behavioral health outcomes and integrated behavioral health programming to change behavioral health outcomes in the state of Montana and rural places in particular. And so you can see that the idea was that the funds would provide support for, those 4 features. As a result of that, statewide centralized public health network would be formed and facilitate collaboration. And then under that, individuals would obtain mental and behavioral health support, including compassionate wraparound care, et cetera, et cetera. Meanwhile, the idea behind the people who were writing this grant together with me, the idea was that training was going to be ongoing about the social determinants of behavioral and mental health outcomes in schools and communities in rural places. And that discussions, bottom left, are developing with health policy decision makers in rural and tribal locations. This would enable what's in the thought bubble, community-wide changes in attitudes and behaviors toward and about mental health, and increasing awareness of the IBH approach. And then that would lead to what's on the bottom right is basically the outcomes: reduce social stigma around seeking behavioral and mental health support, increased awareness of the importance of an integrated behavioral health approach, and then improve mental and behavioral health and outcomes and decrease healthcare costs overall. So this is another way of depicting the logic behind your program. And I think for many readers and many audiences, this actually is a very friendly way of developing and depicting the logic model, and especially in comparison to the log frame matrix. Now, you may prefer personally the log frame matrix as a way of showing the connections between your inputs, your outputs, your project purpose, and your goal. And one of the things that a log frame matrix does, other than delineate the specifics, like what is an input exactly, what is an output exactly, it also, by virtue of how it's arranged on the matrix, it also has kind of built into it what the logic is behind the project. And don't forget that when we started out on Wednesday, I was explaining to you that log frames are basically built upon a series of logical statements, logical if-then statements. And so that's the flow of the thinking. So you can see here, the flow is the idea behind this particular hypothetical program that is being planned using this matrix. If you put inputs in place, meaning test kits, labor, travel, and so forth, of people moving around the state and doing testing, and people come, then tests are going to get run. That's the output. The input is you need the test kits, you need the supplies and equipment, you need labor, you need people to be able to travel and money for travel. The assumption is that people come. The objectively verifiable indicators are things like you have X number of million COVID tests, you have X number of sites identified, The means of verification, in other words, how are you going to know you had those number of tests and sites? You are collecting data at the sites to verify that that's actually what's happening. You're assuming that people come. If that assumption is met, then tests are going to get run. And then you just zigzag your way across the matrix, and you can see how the logic of the whole thing fits together. And you can also look at your assumptions, and you can ask yourself as a program planner, or ask your team, are these assumptions good ones? And are we making any assumptions that if that assumption isn't met, it's a killer assumption? And if there are any killer assumptions, then you would want to have a conversation with yourself or your team about how that was going to be managed or mitigated so that the program can meet its goals. Okay, so that's how the matrix, the log frame matrix, can in and of itself be a depiction of the logic model, or also known as the theory of change behind the program. So I would say, of all of the components of these, 10 pieces, the things that are most likely to be the centerpieces of your program plan that you want to have in writing, that you're going to present to a potential funder or your colleagues or whatever, the log frame matrix and the text statements that accompany it, that explain the logic model, are probably the most important. And if they're missing, like I said before, then you have yourself a problem, or whoever wrote the plan did. So this is the first thing that I look for when I'm evaluating a program plan. I always want to see, what is the logic model? What is these folks' theory of change about how these program components are going to address the problem they are supposedly addressing? And then, how have they laid out the logic model? Is it using the matrix? Is it some kind of more freestyle schematic like in the previous slide, or what is it exactly, and how much thought have they put into it? So some of those other things, like the problem tree and then the objectives tree that I'm going to show you next, they're functioning sort of in the background. Like, you don't necessarily have to put your problem tree into your written program plan, but it should be a step that you consider either individually or together with your team. Okay, so objectives, which do lead to objective statements and so forth, are what I want to talk about next. Okay, so objectives, they are really important because they take that problem tree that you developed in step 7, and they transform that problem tree into a set of objective statements that are positive in nature. So for instance, a problem statement could be something like, no one knows what public health is. And an objective statement is, we will educate our partners about public health by doing X, Y, Z. So you can see how you just flip the notion on into a positive direction, and you say what we're going to do to address this problem that we've identified in the problem tree step. And problem trees are similar to, objective trees are similar to problem trees in the sense that they're read from the bottom up. Okay, so objectives, like indicators or metrics, which are used in evaluation, and I'm going to come to them obviously later in the evaluation portion of the webinar, but objectives, like indicators or metrics, should be SMART. So you probably heard of this acronym before, the SMART acronym. It's like SWOT analysis, strengths, weaknesses, opportunities, threats. Like SMART and SWOT, lots and lots of people use these acronyms. So this might be familiar to you from other contexts in your work life, but basically, in a nutshell, you can see on the slide what SMART as an acronym refers to. Objectives in this case should be specific. They state what you'll do, and they use action words. They should be measurable. They provide a way to evaluate using metrics or targets. They're achievable. In other words, they're within your scope of your or whatever the program team is, and they're possible to accomplish. So for instance, you wouldn't want to say, if your team included 3 people who work for the county, you wouldn't want to say that you're going to change maternal mortality for the entire state. That would be a deal killer for any funder, because that's obviously not achievable by a 3-person team in a single county. And so that's, an example of achievability. And as program evaluators that are looking at program plans and, helping figure out if they should be funded, the achievability is always one of the first things we would look at, because it is an indicator of whether or not the program planners themselves are experienced enough to recognize, like, this is within bounds, this is achievable given my team, or it's not, and they've maybe over proposed or over promised and so forth, which is an indication of, lack of experience on the ground and things like that. And so we would want to go back to the team and say, hey, this needs to be modified in the following ways, because what you've carved out here is not only it's very laudable, but it's, in addition to that, not achievable. So achievability is definitely a key one. Relevance is the R in the acronym. It makes sense within this schematic here says job function, but within the program function of your particular division or office or team's particular functions. In this case, this schematic was developed for business context, but it improves the business in some way, but we can translate to, it improves the work of your, say, your lab or your division within public health or what have you, in some concrete way. And then time bound. Objectives should have reasonable start and end dates that are linked to the feasibility and achievability of the particular program components or activities of the initiatives that are described in the program plan. Okay, so this is an objectives tree. And again, like the other pieces I've described, you read this from the bottom up, and the means are at the bottom, the ends are at the top. So similar kind of thinking as to how to read this and how things are connected as in the objectives tree. So, or sorry, in the problem tree. So this objective tree here shows that the means toward achieving the end start with COVID education, testing centers, and affordable testing. That leads to COVID infected individuals being identified through the testing, contact tracing being initiated as a result of the testing, and then the transmission of COVID is contained, is the end to this particular hypothetical program. So again, this isn't something that's necessarily going to appear in the written version of your program plan, but it could, if you find it useful, to sort of delineate the relationships between means and ends. Or if you're writing for a particular kind of audience that you may think is, a more naive reader that needs more of the blanks filled in for them to help them understand how you move from, means to ends, etc. You can certainly include this, but this kind of schematic isn't always included in a program plan. It is often just in the background conversations that people are having with themselves or their teams. Okay. So that's the point at which I was going to pause and ask you all for to complete the second poll that we put together. So I'm curious, for folks who are participating, have you used a theory of change or logic model approach in any of your own project planning or reporting in your job as a public health practitioner or somebody in an adjacent or auxiliary role? Like, I know Jennifer is not squarely in public health, but works in an auxiliary position to support public health outcomes. So, so go ahead and submit your answers to that very simple poll that we've put up there. Everybody see the poll? I'm wondering, it says, it's not giving me, normally it gives me results as we're waiting for it to finalize. Can you see results clicking in, Kat?
Yeah, I can. And it looks like it says 6 of 7 people have participated, but it's
Okay.
50-50.
Okay, that should be good because we have 3 people on the call who are not out of a total of 9 that are our staff. Okay, so about 50-50.
Yeah.
Okay, interesting. Good to know. All right, so what I want to do next is just very briefly hear from people. Maybe we could put people into the breakout rooms. Let's see, how are we doing on time? Yeah, let's put the people in the breakout rooms for just 5 minutes and have them just apprise each other of what program planning or theory of change or logic model type of approach they've used already in their programs. Thanks, Kat. So good. I'm just curious then, what did you all discuss in your rooms? Did you find that people had experience already with different kinds of ways of using logic models, or are people completely naive to this approach? Jennifer, what happened in your group?
So this type of model is something that we use often to reevaluate what the needs of the community are. We did a similar logic model when we set up the vaccine clinic here for how to support ancillary needs for the community. Is this a long-term goal, a short-term goal? Do we have capacity, space, resources to do it? And then we also use this when we're building different service lines. What is the population need, for diabetic care or dialysis care in the community? What do we need to do to help support that? But what we don't typically do in a hospital setting is the behavioral theory change behind it. We just kind of look at a needs assessment, but not a scaling assessment for how to make that pay. And Sarah talked a little bit about it in her nursing experience and working in dialysis for how she supports patients' behavioral changes to remain successful on dialysis and the things that they need to do. And so she did actually have some good experience in that as well.
Which Sarah was that? Sarah Dobson?
Sarah Black.
Sarah Black. Oh, hey, Sarah Black. So when you're talking about that then with the group, are you familiar with using different kinds of social and behavioral science theories, or are you saying that you just make sure to work the logic model in terms of the problem tree, the objectives tree, et cetera, and then moving toward scaling at the end?
Right. In our setting, we don't use a lot of those behavioral theories behind that.
Yeah.
We kind of look at the relevance, the economics, the capacity, and we definitely do SMART goals, like what fits right now for this environment. But the backside of that feels more like an individual component for how to make individuals more successful in that.
Right. Yeah, so we teach a class here in the School of Public Health, which is on social and behavioral science theory and how you can use the findings from either behavioral economics or psychology or social work or even anthropology, sociology to feed into and create a foundation upon which the problem tree and the objectives tree rests. And that in that way, it can help kind of connect to the evidence base. And oftentimes scientific or research papers that are out there in the literature will start there. They'll start with, we use the health belief model, or we use theory of reasoned action as a way of understanding why we expect individuals to change their behavior in the following ways, or what have you. And so that's a component that you do sometimes see added on to the very kind of basic skills that are taught in the program planning. So we actually offer those as completely separate classes in the School of Public Health here. So Sarah, now I don't think I remember from your intro, what county are you in and what's your role?
Me, Sarah?
Sarah Black, yeah.
Okay. I am in Missoula. I have been a dialysis nurse for the last 8 years, but now obviously I'm going into public health.
Yeah, yeah. So that's interesting. And Jennifer, it sounds like the work that you, or the planning work that you've done in the clinical setting, it mimics and or maps on almost identically to what we're doing here, but like with a different lens in a way, and some different pieces.
Yeah, I completely agree with that. I'm surprised how tightly it overlaps. Oftentimes, like from the hospital side, it's about meeting a need, and so we often are serving as an ancillary component where another facility is coming to us and saying, we're having an outbreak with whooping cough. Like, how can you help us facilitate getting to the appropriate outcome? Or we're not always driving that. We're in the logic model. We're on the tree, but we're oftentimes a support service towards that.
Yeah, that's really interesting. And it makes me think that it might be instructive for people in the webinar to think about the difference between meeting a need that's an immediate and urgent versus you're in your office, you're reflecting on community health needs that have been, say, identified by a needs assessment. And you're thinking, what can we do? What can I do or my team do to address this need that's out there, but it's not so immediate and urgent that you're like, forced into immediate action. It's more like, okay, we have some serious problems in our elderly community in this rural place where I live that have to do with falls. And so now we're responding to a problem which is serious, but it's not immediate and urgent in the same way as a whooping cough outbreak. And it gives you an opportunity as a public health practitioner to go, okay, what are the upstream effects on people's lives that are causing them to have a higher, have an elevated risk of falls? Okay, now we're into the social determinants of health because we're thinking about the built environment. We're thinking about the physical strength of elderly people and why that is or isn't maintained in places where they cannot routinely exercise in winter or what have you. As in many of our rural communities, people have especially elderly people have a really difficult time exercising in winter because they can't go walk in the mall or that sort of thing. There's no sidewalk or it's not plowed or shoveled and things like that. So what I'm teaching you in the program planning and evaluation webinar in this instance is a more, it's in a different scenario than what you're describing, Jennifer. It's less immediate, less urgent. It's like, okay, we are looking at a big problem that we want to scale out, and how can we holistically approach this problem and pull in all these different kinds of stakeholders and things like that. So, but it's good to know that in the clinical setting, there is a very similar and sounds familiar and comfortable way of doing this kind of thing. Not surprising.
It's very interesting to me because to see the way the logic models are put together, after somebody has developed that, who's working in, with public county health or whatever, like how it comes to be that they reach out to me.
Yeah.
Right. After they've developed these things, they've identified their problem and then they move on to trying to identify resources. Like that seems to be the part where I come in.
Yeah.
Right?
Oh, that's fascinating. Yeah.
Right.
Huh. So you feel like it's helping you recognize like where in the scheme of things where your office and expertise fits in.
Yeah. Yes, I mean, it's fascinating to me to see the other side because obviously, like in the hospital, we're not involved in that. Somebody reaches out and says, do you have available resources? Are you familiar with this? Can you point us the right direction? After they've put together, like what are our obstacles? How are we going to get these resources together?
I'm so glad you said that because it makes us remember the stakeholder analysis. And it strikes me that maybe if the public health practitioners that were working on, say, the whooping cough thing had done more thinking or outreach at the stakeholder analysis part of their program planning, you would have been contacted earlier.
Right.
And then you guys together could problem solve about supply chain problems or your actual ability together with your team to meet needs and so forth. And maybe hypothetically, the program plan that they devised could have been stronger.
I 100% agree with that. And
Yeah.
when you were showing your model around some of the barriers with COVID testing, if we had testing, would they come? You know, do we need to test? Do we prophylactically treat? What are the protocols? What are your turnaround times?
Yeah.
You know, we in Missoula, when that little outbreak happened, laboratory support wasn't involved at the beginning. You know,
Weird.
we didn't get involved until I reported cases coming out of our ER where parents were
Interesting.
I notified public health, hey, this is something unusual.
Yeah.
Right?
Wow.
Are
Fascinating.
you aware that this is back in the community? Where on my side, I have access to vaccination records, testing, turnaround times. So like a hospital does have a lot to bring to the table in those type of public health settings, you know.
Yeah.
We're kind of, I mean, we're not in the planning component as much as the stakeholder setting.
Yeah. Ideally, you would be, I guess is the moral of the story from my webinar. Yeah. And what about the other group? What all experience did you have with program planning or theory of change logic model approaches therein? Sarah Dobson, are you the spokesperson again for?
Yeah, I can share what we talked about. We both had similar kind of experiences, like had been introduced to like these frameworks, but hadn't necessarily like used them in our work yet, both kind of being newer in our roles and just kind of seeing how we can apply this. But I'm involved with our like community health improvement planning work here at the health department, but just like in my time here, I've just been in like the implementation kind of phase of that, not necessarily planning out like how we're going to address the needs that were identified. So I see it definitely being applicable and being able to use that. I just haven't done that yet.
Yeah. And is Nina in the same program or county as you? You guys are both over there in Gallatin?
She's Lewis and Clark.
Oh, she's Lewis and Clark. Oh yeah. Okay. Yeah. It is frustrating to come in at the implementation phase and see, it can be frustrating and see like, oh, if only, I wonder if what would have happened if we had done this a little differently, et cetera. So I think that's inevitable, but I guess the idea behind this really solid approach, if you follow it with fidelity to program planning, is to, you know, kind of ward off as many of those conversations as possible down the track. All right, well, thanks for sharing that stuff, you all. That's really informative and good to know about as well. I thought I would move now into the evaluation portion of our time together. And I wanted to give you a little bit of history and context. I have studied evaluation and done evaluation a lot. I really love it. Like I was saying before, I do enjoy kind of geeking out on this. And I like to put it in its historical context because I think it's so interesting. It's a social science research method-based activity or set of activities, and they are devised and designed around investigating the effectiveness of either development aid or community development programs, or you know, they could be health related or other kind of social program as well. So this originally, it was started in the 1930s, actually in a more corporate setting. So that's the picture at the top right of Western Electric Company. And this in this instance, what was happening was that the company wanted to understand better why its outcomes were poor in terms of productivity and worker compliance and whether or not they were meeting their production goals and things like that. And they were trying to understand what the ins and outs of why they weren't always meeting their goals when they thought they should have been, and what it had to do with productivity on the part of the workers and the workers' effectiveness in their respective roles. And so this whole evaluation set of activities did start outside of a social program context. It started in the corporate one and the business world, but it was quickly adopted as time went on into other sectors, including eventually into international development, and then into public health programming and other kinds of social programming here domestically, and in pretty much every other country on earth. So now, like I was saying in our Wednesday call, it's a expertise, and it's a job description in and of itself. And you can go to graduate school just to study program evaluation, program planning and evaluation, and become an expert on that. So in the US, the call for program evaluation over the decades has kind of waxed and waned, and it sort of depends in part on politics in some interesting ways, and how interested our legislators are in, or have been in, understanding the way that typically tax dollars are being spent and the effectiveness. And so over the years, we've seen different kind of frameworks rising and falling in popularity, and a heavier or lighter emphasis on evaluation. And so that's all some of the historical context that I think is interesting. So assessment in evaluation usually occurs across 5 domains, and those include need, design, and execution. So is there a clear and measurable need for a program or a set of initiatives? How is that set of initiatives designed? And then how are they executed? So that might be pertaining to specific project elements and the service delivery of those elements, et cetera. And then what is the impact of the program, and how efficiently was it carried out? And efficiency can be measured in a variety of ways, but some of the key ones would include efficiency in terms of financial expenditure on the program, but also efficiency in terms of time. So speaking of time, I'm just minding the time so that we can break at the top of the hour in case anybody needs to take a bathroom break or what have you. Okay, so practically speaking, challenges are pretty substantial in doing evaluation. And so there's been quite a bit of scholarship and writing and research on why evaluation doesn't always succeed, or what its pitfalls have been. One of the reasons for evaluations to fail is that programs are unfolding, are being executed in human societies, and human societies change over time. And so the longer a program's time horizon is, the more likely it is that there will be some kind of change that's happening in the social community, in the human community, either political change or economic change, or even a pandemic breakout or things like that, that can really affect the circumstances under which the program was originally imagined to be unfolding. And so that can oftentimes lead to programmatic change that is either poorly understood, or people just lack the capacity to measure and really capture and understand that impact of those circumstantial changes on programmatic changes. So that's a reality, a very practical kind of reality that exists in all programs, but especially in ones with longer time horizons, like longer than 2 years. That would be a very common sort of pitfall, to see evaluations of programs and programs themselves unable to meet those circumstantial changes. There's also always a tension between scientific and pragmatic considerations. So like all research activities, there are ways of doing research that are more costly in terms of finances, in terms of personnel, use of staff time, and just time generally. Things take more complicated research programs or research activities take longer to undertake. And so there is, in evaluation, there's the same sort of problem. You can do evaluations that are very simple and high level, that are quick and they're inexpensive, and somebody without a lot of research background or training can undertake them, but they don't always, when they're simple, they don't always do what they are supposed to do or need to do. So the gold standard is the randomized controlled trial. That means you're setting up an experimental design where you're comparing people who did not experience the intervention in the public health program, say for instance, if we're sticking to public health, and comparing their health outcomes with people who did not receive the intervention. And how you place people into two groups is ethically challenging, especially when the intervention can be life-altering or life-saving in some cases. And so there are all kinds of ethical, but also feasible problems around using randomized control trials in public health research and public health evaluation of public health programs. So often we are not meeting that gold standard of the randomized control trial, but we're using other experimental or research designs to help us understand what was the need for the program, the design of the program, the execution elements, its impact, and its efficiency. So we're using other ways of understanding those things than a typical sort of experimental research design or randomized controlled trial, because those are rife with practical problems, like they're too expensive or ethically challenging. So budgetary constraints are also very common in evaluation. Very typically, when people do put together budgets for programs, they do not budget sufficiently for the evaluation arm of the program. And so oftentimes you find that people who work in the evaluation realm are struggling to meet the expectations of the program implementers in terms of what kind of evaluation is being done, because they under budgeted for it. And so evaluations oftentimes end up being too high level because they lack sufficient budget or time allocated. Another challenge is the importance of asking the right question. And that comes to the next point on the slide here, which is that all evaluations need to be clear on the difference between things like outputs and outcomes, and how to frame the question, how to frame the right question that you're asking, to get at two very different things within time, ethical, and budgetary constraints. So if you remember back on the log frame matrix that I showed you before, you have outputs, which are sort of like the widgets of the project, like X number of tests were done, or X number of vaccinations were delivered, or X number of trainings were delivered. Those are things that are easily countable. Those are outputs. But outcomes, the result of those outputs having been output or having taken place, can be a lot harder to measure. And oftentimes what happens here at this stage is people get caught up in making attributional mistakes. In other words, they attribute changes in say the disease, for instance, that they're trying to affect, or the health behavior that they're trying to affect. They attribute changes incorrectly. Either they think that their program had an impact on the health behavior or the disease process that it didn't, or they underestimate the effect of their program's impact on that health behavior or that, say, disease process. I wanted to give you a couple of examples from my work in East Africa, where I've worked extensively on malaria and malaria control programs. And so bed nets are distributed very widely across sub-Saharan Africa. And they are one of the principal program components that you see in pretty much any malaria program anywhere in the world, because malaria is transmitted by mosquitoes, and the mosquitoes that transmit them are of a particular species called Anopheles, and those mosquitoes only come out at dusk and dawn when people are usually in bed. So by distributing bed nets that hang from the ceiling and come down over the bed and ideally are tucked in under the mattress, you can protect yourself from those mosquitoes, and thusly you can protect yourself from getting malaria, which, as you know, most people on the call would know who've traveled or are aware of tropical diseases. Malaria is still one of the biggest killers in the world in terms of tropical diseases. And so unfortunately, there are lots and lots of programs that have distributed bed nets, and what ended up happening with those bed nets was not what was intended. And so the pictures on the bottom left-hand side of your screen are two very typical uses for bed nets, anti-malaria bed nets in Uganda, one of the countries where I work. And one is to make a wedding veil for brides. So you can see a beautiful bride with her wedding dress on and her wedding veil on her wedding day. And that is in fact a bed net. And fishing with them is another really common activity. And so that brings us to the question of asking the right question. So in many instances, it would be an evaluation that wasn't results oriented, but was outputs oriented, would simply ask the question, how many bed nets were distributed? And in the instance of, countless anti-malaria programs across sub-Saharan Africa, including in Uganda, it might look like you are really achieving a lot because you're distributing tons of bed nets to people. But in reality, on the ground, the result of that in terms of reduction of malaria is very, very slight, because the number of bed nets that are properly used is pretty low. And so, sometimes we'll see misattribution occurring with respect to the with changes in malarial incidence and prevalence and things like that, which are in fact related to climate changes. Like there was a very long dry season, and so there just weren't as many mosquitoes around. Here we are in the international non-government organization sector, where people are working on these bed net distribution programs, and I'm thinking, wow, we're really hitting it out of the park here with our anti-malaria program, with our bed nets, so effective. But in the absence of asking the right question of how are those bed nets being used, how many of them are being properly used, and what is the incidence of malaria in families or individuals who are using them properly compared with those who are not, those are the right questions to ask. And so I guess the moral of the story here is that asking the right question in evaluation is very, very important. And it's often not done right. And the reasons for that are because asking the right question is usually more complicated and it's more expensive. So I'm sure that you can all, because of, existing in the world and also working in the health sector, you can probably come up with many, many examples in your own work and your own background of where an evaluator would mistakenly be measuring the wrong thing or at the wrong level, and either say, oh, this program is really amazing and it's doing all these things, or it's not, and maybe it actually is. They still haven't asked the right question. So asking the right question is so important. All right, so basically what I'm saying here is metrics or indicators that we measure in evaluation that are simple and easy are usually inadequate. And so the cartoon on the right-hand side of your screen here shows the people lining up, and so many people are taking the simple but wrong path, and so few people are taking the complex but right path, and that isn't that life. Certainly not unique to evaluation, but definitely a component of evaluation science and something that we all sort of struggle with. Okay, so programs that are actually easily measured with simple metrics are often the result of an oversimplified problem. And so an example of that in the global health world is if you look at the difference between selective and comprehensive primary healthcare programs versus like vaccine programs. So a comprehensive or multi-pronged primary health program that is focused on, say, a diarrheal disease like cholera, would want to change people's toileting behavior and change people's hand washing behavior and change people's behavior around purifying water and so forth. Whereas a vaccine program would just target immunizing people against cholera or typhoid or other diarrheal diseases. Those programs are simpler. Vaccine programs are a great example of a program that is simple, but it doesn't target the, they're simple and they're also easily measured because it's very clear. You deliver this number of vaccines to this number of people. That's very easy to count and very cheap to count. But if you want to look at the incidence of diarrheal disease in terms of the upstream effects, before people are sick with diarrheal disease, you want to change all these other components that I just mentioned, like hand washing or toileting behavior and so forth. Those are much more expensive, not only to enact and execute as programs, but they're also much more complicated and difficult to measure. You need way more indicators or metrics and much longer time horizon and so forth. Vaccine program, not to say they're not good, but they don't necessarily target those upstream effects that are causing diarrheal disease in many human populations on Earth still today. So, so these are some issues around the history and context of evaluation in public health, whether we're talking domestically or globally. M&E refers to monitoring and evaluation. So monitoring, like I mentioned previously, I think in our time together on Wednesday, is more focused on the outputs level. So monitoring is just like, we did this number of activities, we delivered this number of vaccines, et cetera. And evaluation is its companion piece, and that's more focused on outcomes and program goals. So that's the more like the 10,000 foot view. Now, M&E together are usually paired. They're two sides of the same coin of assessment and evaluation activities that have to get done to see how good a program is. Now, we can compare that with audit. So oftentimes when you're engaged in evaluation and maybe some of you might get interested in evaluation and end up doing evaluations of other people's programs other than your own. Sometimes the people in the other program that you're evaluating, when you're not a member of that team, can feel like they're being audited, like it's a financial audit or something like that. And that makes people uncomfortable. They feel like, oh, maybe if the evaluator finds something they don't think is good or effective, maybe my job could be at risk, et cetera. And so sometimes when we are working in evaluation, it can feel a little off-putting to people or a little confronting and worrying. And so the importance of understanding that is related to the importance of building evaluation into program planning from the get-go, so that from day one out of the gate, everyone who's involved in program planning is also involved in designing evaluation activities that are going to help us understand the importance of different program components and how well we're doing them as program implementers. So the other thing that I wanted to circle back to is stakeholders, and the reality that when you do a proper stakeholder analysis, one of the things that you're looking for is the ways in which stakeholders might have competing priorities. And so they can say, for instance, if you're involving your stakeholders in program planning, as you should, as I think we heard from Jennifer in that important point that she made earlier, involving stakeholders in program planning is critical, but you also want to involve them in evaluation. In order to do so in a sophisticated and savvy manner, you have to recognize that they might have different and oftentimes competing priorities vis-a-vis the program. And so that can affect the way that they think about what metrics they want to push for in terms of the evaluation part of the work. last, I wanted to talk in this section before we take a break on the difference between in-house and outsourcing your M&E. So most of our public health offices don't really have, in the state of Montana, we don't really have the capacity or in the budget to outsource our monitoring and evaluation to somebody else. Ideally, that does happen, because outsourcing does happen because it means the evaluation team is going to have a fresh set of eyes. They're more objective. They're less, they may be less partial to certain program components, or even certain staff members, or less likely to say, well, I have a little bit of a problem here. You've got a little bit of a weakness here, needs to be addressed. And so that objectivity is seen as a good thing. The downside to outsourcing your M&E, not only is it expensive, and most of us lack budget for that, but also it's more difficult to have the evaluators in the program planning stage of the game. So if you're doing your in-house, your own monitoring and evaluation of your own projects, there are definitely upsides to that in terms of engagement early in the program planning process, and making sure that evaluation goals and activities that need to be undertaken to complete the evaluations are understood by all members of the team, so that nobody finds that to be alarming or concerning or anxiety producing in any way. Okay, so I'm going to pause there, and I'm just going to stop my screen share because we are going to take a little bit of a break so that people can use the bathroom or what have you. And then we'll reconvene in, let's say, 7 minutes. So we'll take a 7-minute break here. All right, everybody. So I'm back. My timer just told me we are up to 7 minutes. So I'll keep going here. Kat, I'm seeing you're in agreement. Okay. Just get back over to my slides here. Does that look good, Kat?
Yep, that looks perfect.
Okay, excellent. All right, so now you may all be wondering, where does monitoring and evaluation fit into the program management cycle? And so you can see here that it fits everywhere. It's really at the center of everything that we should be doing as both program planners and implementers. And so I have a Nepali colleague who always says that evaluation is like using your blinker when your signal when you're driving. Like you can't do program implementation without it. It should be something that you're doing all the time. So you can see here, if you think about the program management cycle, starting with at the top, program identification, cause analysis, objective goal setting, designing implementation, and implementation and service delivery, and all kind of feeding back on one another. That monitoring evaluation sits right at the center of that. And that goes back to a point that I made earlier in our time together, that a mid-course correction is very normal and suitable and very good, and shouldn't ever be thought of as like a bad thing or a sign of weakness, but instead a sign that the evaluation and monitoring activity associated with program implementation are feeding back into the work in an appropriate manner. You don't want to leave it all until the very end when it's too late, obviously, to make the changes that need to be made. So if you are interested in sort of understanding the delineation between monitoring and evaluation a little bit more, I've mentioned before that monitoring is often kind of more focused on the output stage, whereas evaluation is more focused on the higher level, like the outcomes and the goals stages. Another way of thinking of that is depict what was expected to happen. So always going back to the timeline of the program that was originally envisioned. And then you can compare that on the other side with evaluation. It's assessing achievement against preset criteria. And it's got a variety of purposes and distinct methodologies like process, outcomes, performance, et cetera. So evaluation activity can be of really any program component. It can be evaluation of the process in and of itself, of your progress toward the stated outcomes. It can be oriented toward the performance of an individual program staff person or team, et cetera. So these are all very typical ways of kind of aiming evaluation activities, and you will design whatever is appropriate for your purposes in your own program implementation scheme. Okay, so in that way, you can understand evaluation to have different foci depending upon what it is that you're interested in understanding. So we can start with inputs. And these are, as I've said before, resources provided for activities, or that could include things like cash or supplies, personnel, equipment, training, and so forth. And let's compare that with outputs, the next level up. And that's the specific products or services that an activity is expected to deliver as a result of receiving the input. So you can remember from before in the log frame matrix that I developed for COVID testing, the outputs cell was filled with the number of COVID tests that were delivered. And then outcomes, again, just kind of drilling down into what that refers to, it's people's responses to a program. And are their behaviors changing as a result of the program inputs being delivered, the outputs being executed, and so forth. And they're more short-term. And then impacts are the more longer-term things, like what are the impacts of the program in terms of addressing maybe upstream effects of the problem, the health problem, or the health behavior you're trying to change. And again, here we can see the social determinants of health components coming in. So the impacts level looks at things like economic, social, organizational, so forth, these kinds of things that are either intended or unintended results of the program. These are more long-term. So whereas outcomes are more short-term, the impacts or goals level are more long-term. And ideally, programs will have both. They'll have both short-term and long-term impacts. So before you start planning, the evaluation is where it's at. And so in the same way that you have to plan your program, you have to plan your evaluation. In the same way that we want to start with where we're ending in the program planning and walk ourselves back from the endpoint, in planning and the evaluation, we really want to do the same thing. And so oftentimes what I like to do in terms of planning and evaluation is I want to think about, okay, what do I want to get at the end of this? Do I want to have a report that I'm delivering to the program implementers? Or do I want to have a report that I'm delivering to the funders of the program? Or is the result of this evaluation going to be a publishable paper or a conference presentation? Do I want to talk to the Montana Public Health Association next year about this program and what it got done? So then once I answer that question, then it becomes a lot easier to walk myself backwards from that. What does that audience want to hear? To give them the information that they're interested in hearing, what information do I need from the program? And so in that way, you walk yourself back from the endpoint. It makes the preceding steps much easier to envision. So that's determining the purpose of the evaluation. You then want to think about the type of evaluation. And there are three main types that we have in evaluating pretty much any kind of plan or program, but certainly in public health. And those are the baseline, the formative, and the summative evaluations. So baseline is oftentimes also referred to as a needs assessment. And that's to just start at the beginning. Where are we? And oftentimes the reason that you want to have evaluators and people who have an expertise in evaluation evolve from the get-go is because their research skills can help you determine the baseline needs in the community that you're going to be addressing. They help you, or those activities at the baseline help you understand your progress toward your ultimate goal. Obviously, if you don't know where you started, you can't say we moved the needle from 30% of people were engaging in activities related to substance use disorder at time 0, and 15% were at time 1, you can't make those kinds of comparisons if you don't know what's happening at the beginning. So midpoint formative, that's obviously, you can tell from the name, happening halfway or part way, whatever the part is, third of the way, 2/3 of the way through the program. This is the evaluation activity that allows you to make the mid-course correction that is oftentimes so important. Summative, as the name implies, is summing it all up at the end. It's a retrospective and looking back at what's been accomplished. Okay, it's important to decide who conducts the evaluation. Again, is it in-house or outhouse, or outsourced, outhouse? You can tell I have a particular interest in toileting behavior and latrines, which is one of my areas of expertise. Not outhouse, outsource. Are you gonna do your evaluation activities with your existing team, or do you have budget to hire somebody else to do it? So then you obviously you have to review existing information and program documents in your office, including previous monitoring information from auxiliary or adjacent projects or programs that had either similar methods or what have you that you can call upon or draw from. What are your available information sources? And then you have to describe the program. And then the asterisk brings you to the bubble on the right in dark green. How is it all working? So being really clear on the evaluation side of the shop, what are the objectives, strategies, management processes, and so forth that are going to be put into place to make this program happen. And those can include all of those kinds of considerations that you see in the bullets underneath there. Okay. Last but not least, you have to assess your own strengths and limitations. And so that will feed into questions that you might want to answer about how in-depth your evaluation is going to be. You may need to do a simple and cheap and quick evaluation because you simply lack the resources in terms of personnel, staff time, in terms of budget, and so forth to do anything more than that. So that's very common, and it's not bad. It's better than doing nothing. It's not as good as it could be, but knowing that you're going to have to limit yourself there and coming up with a rationalization or a justification as for why is certainly something that would be very appropriate and also very common and normal to do. Okay, so you want to look at appropriate evaluation methods next. These are determined in part by the evaluation goals and objectives. You're going to want to spend some time formulating your evaluation questions and sub-questions, and that is going to be driven largely from, are you at the baseline, are you at the formative, or are you at the summative stage? And then what is the appropriate evaluation design? Typically, we're not, like I said, seeing a lot of experimental design. We're not seeing a lot of randomized controlled trials, although you do sometimes see those. It's more common to see like baseline compared with follow-up. Here, we started here at time 0, we ended here at time 1, or we ended here 2 years later, we ended here 4 years later, etc. So a baseline follow-up evaluation design is very, very typical in the field of public health and tends to be like a feasible and affordable and manageable type of evaluation design, and as such, very common and very appropriate oftentimes. We are going to be looking at measurement standards. So I'll talk in a few minutes about metrics and indicators. And so measurement standards and measurement indicators. And then, of course, you want to figure out your evaluation schedule and budget. So just like the program has to have a timeline, the evaluation scheme should have a timeline, and obviously the budget. So going back to formulating the evaluation questions and sub-questions, assigning different team members to being in charge on the evaluation side of and owning those questions, and linking that to a timeline or a schedule, and linking that to a budget. Those are the kind of advanced work that you want to do in order to greatly increase the likelihood that the evaluation itself will be successful. Okay, so some sample evaluation questions are on this slide here, and they ask you to pan out a little bit and consider what different stakeholders might want to know. So I've distinguished between program clients and program staff, program managers, and funding bodies here on this slide to help you think about how you might want to anticipate what different stakeholders might want to know from the evaluation, and also how to go about answering those questions. So, so some example questions appear here on this slide. For program clients might want to know things like, does the program provide us with high quality service or not? And then drilling down more into the details, are some clients provided with better services than other clients? If so, why? Program staff, by contrast, might want to ask a similar question. To begin with, is the service high quality that's being provided to the clients? And this is a question that would come at the formative stage, should staff be making changes in how they perform their work as individuals or as a team to improve processes and outcomes? And then you can see on the right-hand side, program managers and funding bodies are going to want to know different things. Funding bodies, for instance, are really likely to want to know, is the program cost effective? And so having evaluators across the details on the budget and the finances can also be something that a type of activity that they engage in. Okay, I mentioned before about the SMART acronym with respect to objectives. The same thing, the same kind of thinking can apply to choosing metrics or indicators. So these are the things that we are using to measure our progress through time or our progress toward a goal. And in the same way that objectives should have these SMART components, metrics should as well. So they have to be specific, they have to relate directly to the processes that you're trying to influence. They have to be derived from actual numbers, they're typically quantitative. Measurement should be precise and consistent, no matter who's in the evaluator role, or if that changes from year 1 to year 2 of the grant, year 5 of the grant or program, it shouldn't matter. Obviously, they need to be relevant to the activity being measured, and they should be timely. So they don't get better with age, and they should be measured. Activities should be measured by metrics or with an urgency that matches the urgency of the matter at hand. So for instance, with how severe the pandemic was starting to look, especially in some populations of our country, some demographics, race and ethnicities, et cetera, there were varying levels of urgency with respect to understanding the efficacy of different kinds of, say, vaccine programs and the rollout of those programs among, say, for instance, people of different races with different levels and incidence and prevalence of different kinds of comorbidities that played nicely with COVID. Of course, we know that COVID didn't affect every population the same, depending on health background and some other things. And so in other demographics, the urgency was different. And so in that way, you have to you have to sort of titrate your timeline to the urgency of the problem at hand, or the health behavior that you're trying to shift. Okay, so I've talked here so far today about metrics, and I've talked about indicators, and I wanted to make sure that you understand that those terms are used interchangeably. So whether I'm talking about the one or the other, or you're hearing about the one or the other in your own work, just know that those are typically referring to the same thing. So these are standardized and objective measures that allow the following things, or can allow the following things. For instance, a comparison among health facilities or between health facilities, a comparison among or between counties or between different time periods. And they are also typically measures of progress toward achieving program goals. And so characteristics of metrics and indicators that you want to keep forefront of your mind when you're designing your evaluation scheme would be things like clarity. They're easily understood by everybody. It's really important in terms of programming, public health programming that is public facing, where you are going to be doing presentations to the public, it's going to be covered in the media and so forth, it's oftentimes useful to think about choosing indicators or metrics that will be commonsensical. Either they're going to be things that the public will understand. You may have a suite of different indicators that you're also using that are more complex, that have that are speaking more to the scientific or clinical community, et cetera. And so having a selection of types of indicators that are understandable or approachable by different audiences can also be very important, especially when you need the public. You're going to need the public to buy into your program in order to achieve your program ends. Okay, obviously they should be useful. Indicators and metrics should be representing all of the important dimensions of performance of whatever the thing is. In other words, you know, with the bed nets and malaria, okay, sure, it's good to know you distributed all 1,000 bed nets that the funder purchased for you. They want to know that they're distributed and not sitting in a warehouse somewhere. That's good. But another important dimension of that particular program is how are those bed nets being used? And so more evaluation activity is thusly called for in terms of understanding how the people use those bed nets that they received. Of course, metrics should be measurable. So I suppose that goes without saying, but rates, proportions, percentages are very typical. We have to be clear about what's the common denominator. So what is the population at being measured, and are we capturing it appropriately and correctly? And then reliability is, of course, something that we're considering when we're designing our evaluation design and choosing our metrics. So can the indicator or metric be measured effectively no matter who's doing the work? So they're understandable and doable by not just the public, but also by people who are tasked with collecting the information in question. Okay, and then last but not least, we have validity. In other words, the metric is measuring what it's meant to be measuring instead of something else. So for instance, like again, with the malaria example, if your metric is simply, if you do a bed net study, or sorry, a bed net program, and your metric is the prevalence of malaria, you're probably not measuring the right thing, because lots of things other than bed nets contribute to the prevalence of malaria in a malarial population. And so that would not be an appropriately valid metric to use in a bed net program. Okay, so that means that choosing indicators is extremely important. They do demonstrate the extent to which results have been achieved, and they specify how the achievement can be verified and understood. They are the very foundation of the project's monitoring and evaluation. And as such, they cannot be more important. I really can't overstate the importance of the thinking that you do and the thought that you put into either individually or collectively with your team to choosing the indicators and making sure that they match all of those characteristics and criteria that were on the previous slide. Okay, so further in step 9, in terms of choosing indicators. So this is again, the COVID-19 scenario that I designed as an example. And so you can see in the second column over the objectively verifiable indicators that are highlighted in red here at every stage of the game in the log frame or the logic model, from inputs to outputs, project purpose and goal. Project purpose is also outcomes, so those are also used interchangeably. So you can see where the metric is carefully chosen, that it matches up with what the particulars are in the column to the left. They don't overblow the potential impact of the program activities, but they also don't undermeasure the potential impact of the program activities either. So you can see in terms of inputs, we have the actual number of COVID tests, the number of sites. In terms of outputs, tests run, we have the test results coming out of those tests being run. And we can obviously measure things like positives versus negatives in this instance of this particular example. In terms of project purpose, per capita incidence of disease, and then number of tests run increased from X to Y, et cetera. So these are very measurable outcomes and, indicators or metrics that link up with the column on the left. Okay, I'm just gonna pause here and see if there are any questions before I move on to step 10, which is the final step of the log frame. So step 9 really is the step that in the log frame program planning shows us why evaluation is to be understood as actually a component of program planning. So program planning and evaluation thusly should never be separated. They should all be part of the same endeavor and set of activities. Okay. So just gonna look in the chat. Okay, so no questions coming forward in the chat. Okay, so then does anybody want to flip on their mic if they have any questions about stuff I've covered since the break? And if not, then we have one last poll and breakout room. So Kat, are you ready? Maybe we'll go ahead and launch that poll. So the poll asks you, would you feel comfortable choosing and defining indicators or metrics for a program that you would like to plan? And then we're just going to spend a few minutes talking about what issues, if any, would affect any hesitation that you might have. And I am collecting this information because it is germane to our trainings that we do in the Public Health Training Center. So we have a training that's on research design, and we may need to add other trainings that can help people work through these questions. All right, what are you getting for results there, Kat?
I got 4 of 6 answered. 75% said yes, and 25% said no.
Okay, that's good. So
80-20 now, Kimber.
80-20, yeah. So people seem good with metrics largely.
I didn't make Kimber a co-host, which is why she can't see, so now she can. But
Oh, thanks, I can see it now. Okay, so it seems like most people feel pretty comfortable with metrics, and maybe it's not worth going into the breakout rooms at this point, but I'll just continue on. And we can, in the Q&A at the end, maybe talk about any questions that might come up in terms of indicating metrics or where that hesitation might come from if time allows. And then if you guys want, if people who do feel any kind of question or hesitation around choosing appropriate metrics for programs that you're working on or can envision yourself working on, pop them in the chat, and then Emily and Kat can potentially use that to think about future Public Health Training Center programming that we offer. Okay, so checking your assumptions comes next. So I have 6 points to cover here. When looking at your assumptions, the first thing that you want to do is describe any necessary internal and external conditions that need to be in place in order to ensure activities will produce results. These are basically risks that can jeopardize the success of the project. And what we like to see when looking at program planning on the funding side is that the assumptions and risks are worded positively. In other words, they describe circumstances that are required to achieve certain objectives. They should be relevant and probable. And if an assumption that comes to mind as you're working through this thought exercise, or your team is unlikely to occur, or sorry, if it's not important, if things come up that seem sort of relevant, but end up at the end of the conversation to be not that important, don't include them. Including something in your program planning document or grant proposal, including something on assumptions is absolutely critical. I'm just saying, you know, be judicious about what you include here. If you've got assumptions that are unlikely to occur, or if you've got killer assumptions, some people will recommend that you abandon the project. So it's important to think really carefully about what assumptions you're making, and if any of them are killer assumptions or not. They can really affect the way that a potential funder will look at your program, or even, you know, your manager or the person that you report to, whose job it is to give you the green light on a particular program or a set of initiatives. Okay, so examples of assumptions would be things like politically, that the stability of the government support for the strategy and availability of government staff is going to persist across the number of years of the grant. And so in public health, in our country, we used to think that this was pretty much a given. And I think what the pandemic showed us is, because of the way that information and misinformation and disinformation and politics got all swirled up together, that stability of government support is not as reliable as it maybe once was. And so I think it's really important for teams to think about that, especially if you're working on programs that are targeting a health problem or a set of health behaviors that have a political edge to them. Like I was just hearing on the news yesterday morning about a program that has been designed to help illegal substance users use substances in a controlled setting where clinicians are available to them should something go awry. And it's drawing a lot of negative fire, politically speaking, because people, you know, people of different political persuasions feel one kind of way or another about programs like that. And so really examining assumptions with respect to politics, I think these days is very appropriate. Another is that the economy is going to remain sustainable, that there won't be big shifts in economic circumstances that affect people's health behaviors or health-related behaviors. That's a typical assumption, which with the coming recession or whatever is about to happen may not be a good assumption either anymore. Another is that you'll have adequate funds / materials, that you'll have skilled people, that your training needs of those people will be met, that your approvals and contracts will fall into place, and the legal and administrative side of your work will be managed, and that your stakeholders will participate. So all of these things are examples of assumptions that are worth spending some time on as you plan your program, and or including some language about them in your program plan or grant proposal. So the last thing that you're going to be engaged in as a program planner or evaluator, whether you're an implementer or you're a program planner, or you're on the evaluation side of the team, or you're doing all of those things, you're all wearing those hats, which is very typical in Montana because of, you know, low budget. We're oftentimes doing all of these things, is drawing conclusions and disseminating results. And so I wanted to include this slide because I think it's really interesting to think about how urgent public health hazards are, and whether they're the health problem, health behavior, or disease process, or what have you, your work is focused on, is considered a hazardous one. If it's considered like no hazard with no apparent public health risk, et cetera, or if that's unknown, how that might affect the way that you determine conclusions, assign conclusion categories, and also determine recommendations and public health actions. So we're going to distribute these slides to your emails after the conclusion of the webinar. So you can take some time and look through this schematic more if you're interested. But I think it's important to think about with respect to drawing conclusions at the end of the work that you do. You're going to want to report back to your funders, or minimally to the person that you report to, or the person they report to, about what the result was of spending all this time and money doing these program activities. And so, framing those conclusions appropriately is extremely important. So in terms of describing results, an example from a summative evaluation, so this is at the end, kind of looking back retrospectively at the end of the timeline, we would be asking questions like this: what were the outcomes? We would include things like data on the primary outcome measure or measures, compare it to the baseline if the baseline is available, and hopefully it will be if you are engaging carefully in the log frame approach to doing program planning. So you did do a needs assessment or a baseline at the beginning. So comparing to the goal, comparing to benchmarks would also be very appropriate, say benchmarks that were set in similar communities dealing with similar health problems. And then providing data on any secondary measures that can also support conclusions about program outcomes. So these are kind of outcome related questions that would be very appropriate to put in a summative evaluation that's looking back. What else did you find out? So you would want to answer any additional questions that came up along the way. So with respect to the COVID testing one, a mid-course correction would probably have something to do with changing attitudinal factors in the community that we were working with here in my case, Western Montana, where people, say for instance, on the university campus had really different attitudinal features toward COVID testing and vaccination than our counterparts just down the Bitterroot Valley, who had really different feelings toward the same kind of health behaviors, the same kind of interventions. And so the mid-course corrections that we saw people making pertained 100% to answering new questions that were coming up as we went down the track on implementing programs relating to COVID-19. And so the summative report should address that, those kind of mid-course corrections, additional questions that came up that drove them, and so forth. Additional findings and lessons learned would also be appropriate. Using graphs and displaying information visually is something that is going to really enhance the quality of the work that you do put into your program summative report, or if you're on the evaluation side or doing evaluation related activities, this is also, displaying information visually in the formative or mid-course evaluations is also totally appropriate, of course. And so, using graphs of different types, like line graphs or bar charts, pie charts or scatter diagrams, et cetera, is very, very typical. Unfortunately, most people working in our field have some facility with data management programs like Excel through the MS Office suite, or other similar programs that are very, very user-friendly and help us display information visually using graphs with literally just a couple of clicks. And so I wanted to talk a little more at the very end here about when you're using those visual representations of information, we want to do two things. One is avoid chart junk, and the other one is avoid excessive data ink. So chart junk is on the left here and pertains to graphs. Oftentimes people make unnecessarily cluttered graphs, and that the clutter really doesn't add anything to our understanding of what's being visually displayed. And so I just wanted to plant the seed in your minds for those of you who are preparing to do either really any kind of evaluation report, be it a baseline, formative, or a summative one, that these are some of the things that you should have in the back of your mind as you're going about this kind of activity or this type of reporting. So chart junk, charts, also known as graphs or figures, can be unnecessarily busy, but so can tables So the tabular presentation of data should be as simple and elegant as possible, and appeal to the eye and your audience. And so you want to think also about the audience members that you're shooting for and who you're trying to convince of one thing or another, because some people are more attracted to graphs and other people are more attracted to tables, and still other people don't have any facility really with either. And so for those of us who are working with audiences that are either afraid of say quantitative data or math, or phobic, math phobes, this is so common in our country. I think it's really important to think through like quite carefully, like how we are communicating results from the evaluation activities that we do to make it as user-friendly as possible. Okay, so conclusions then in any sort of reporting that's being done should be focusing on two main kind of buckets. One is if the project's goals were met. So along the way, what key barriers were targeted and what was the most effective action and why. And then the second bucket is if project goals were not met, what was going on there. So it's all part of the movement in our sector in public health, but also in any community development program outside of the health sector. It's a movement toward acknowledging failure and admitting failure and talking about failure and weaknesses and so forth. So don't be shy. If there were things that happened along the way that you're reporting on in the evaluation phase that were not so rosy and were really problematic, it's okay to talk about that. And funders are savvy to the reality that things inevitably don't all go great. And so not talking about any single instance of something not going great is a little bit of a red flag too. So be comfortable including this kind of thing. Okay, so were there some key barriers that were missed? Were there barriers to implementation that weren't anticipated? Go ahead and talk about what were they? How could they be overcome? Did you get only part way to your goal? Like you changed knowledge and you changed knowledge because you have metrics that demonstrate that, but you didn't change behavior yet? That's okay. It's very common in public health for change to be very slow and for programs to only get part way there. And so talking about that is really appropriate. Talking about things like, did the intervention produce results on other important outcomes that were not necessarily identified originally in the program plan? That's also totally appropriate. And last but not least, and I'll end with this slide, is dissemination. So when you're thinking about who to talk to, I mentioned before that one potential audience you might be considering is Montana Public Health Association or Montana Hospital Association, lots of like internal organizations within our state and other states, if there are folks on the call from other states still, that would be potentially interested in hearing about what the program achieved or didn't achieve. And so we want to go back to what were the original stakeholder groups, and that might include MHA or Montana Public Health Association members and people who attend those conferences, or they might just include, in terms of stakeholders, people in the community, other clinicians, other people working in public health, or maybe just your program manager. So the original stakeholder groups, as we heard in the breakout sessions that we did on that, can be really different from one context to the next, and that's also normal. Okay, so reminding them the needs, goals, and actions is important. Addressing additional concerns or questions, and then address additional concerns or questions that might come up, like be prepared, especially if you're giving a conference presentation or you're reporting in person to stakeholders. It's always good to be prepared for questions that you don't know how to answer, or questions that pertain to activities that were never included in the program from the get-go. So I like to go into those sessions armed with a set of things that I could say if necessary, like that's a good suggestion, we could try it going forward and see whether it helps. Or we did try that actually, and here's what we found. Or we didn't have time, money, or experience to do that, but we can explore it in the future. That's an important one to keep your stakeholders feeling like their ideas are interesting and important and valuable to you. Or we didn't think of that question, but we do have some data that might answer it. I'll come back to you. Or we don't have data to answer that question, but it's a good idea for future study. And then in terms of what you do next, it's always good to be thinking about the broader dissemination scheme. So newsletters, summaries for patients, providers, funders, trade associations, and some of the things like that. So MPHA happens in September, and unfortunately now we're in June, so we're past the time for proposals. But in addition to scholarly journals and popular press, I love to promote MPHA because I think it's important for every single one of you to know that what you learn in your programs, you have your finger on the pulse. And we want to hear, like us on the academic side of the shop, or people like that work in Helena for DPHHS, they want to hear from you. So never be shy about going up to these conferences and giving a poster or giving a oral presentation. You're the people that people want to hear from. So don't be shy. Okay, so we have an evaluation activity that we usually do. Emma, are you sending that out by email, or are you going to put that in the chat box? Yeah.
So we put the evaluation link in the chat box. Kat just put it in there. We really appreciate folks filling that out, and we'll send it to those that weren't able to make it today as well. It just helps us to keep offering awesome content and see where we can improve and what we're doing right. So thank you so much for taking time to do that. Kimber, that was fantastic. I learned something new every time, even though I've seen these presentations so many times now. So very, very appreciated. We're glad everyone could come today. I hope everyone has a fantastic weekend. And does anyone have any final questions for Kimber?
Well, TGIF, everybody, thanks for coming on a Friday and taking time out of your schedule to continue your education and hear what we have to say about program planning and evaluation. Thanks.
Thank you so much. Have a good one, everyone.